Welcome. I'm Dr. Raed Dweik, Director of the Pulmonary Vascular Program in the Department of Pulmonary Allergy and Critical Care Medicine at the Cleveland Clinic. I'm pleased to welcome you to the Cleveland Clinic's Respiratory Virtual Grand Rounds. These are case-based presentations where I invite some of the leading authorities in the field of respiratory medicine to discuss an important topic that I believe is worthwhile to your practice in order to help you be more confident in approaching and managing patients. For today's presentation, I have asked Dr. Marie Budev to provide you with an overview of the indications, patient selection, and outcomes of lung transplantation. Dr. Budev is the medical director of the lung transplant program at the Cleveland Clinic and is a frequent speaker on the topic at national and international meetings. Dr. Budev earned her Doctor of Osteopathic Medicine degree from the New York Institute of Technology, College of Osteopathic Medicine in Old Westbury, New York. She completed her residency in internal medicine and fellowship in pulmonary and critical care medicine at Cleveland Clinic. Dr. Budev is a member of the American College of Chest Physicians, the American Thoracic Society, the European Respiratory Society, the International Society for Heart-Lung Transplantation, and the American Society of Transplantation. Dr. Budev's case-based presentation includes integrated audience response questions that are designed to help you test your knowledge as you follow along. Here's Dr. Budev.
Thank you for joining us today. My name is Marie Budev, and I'm the Medical Director of the Lung and Heart-Lung Transplant Program at the Cleveland Clinic. Over the next 30 minutes, we'll be discussing the indications, patient selection, and outcomes of lung transplantation. But to start off our discussion, let's start with our initial case. The first case is a 59-year-old male who presents with a 2-year history of idiopathic pulmonary fibrosis with increased supplemental oxygen use, both at rest and on exertion. The next step in his care is to do which of the following: A, refer to hospice; B, start high-dose intravenous corticosteroids; C, start colchicine therapy; D, refer for lung transplant evaluation; and E, none of the above. Well, since the topic of our discussion today is indications, patient selection, and outcomes of lung transplantation, obviously the correct answer is refer for lung transplantation. That is D. Advances in critical care technology and in surgical technique have solidified the role of lung transplantation in the management of end-stage lung disease. Over the last few decades, over 32,000 lung transplants have been performed worldwide. The first transplant was performed in 1963, and now lung transplantation is approaching the half-century mark. And this is an incredible option for patients that are suffering from end-stage lung disease, and has become the standard of care for certain patients that have advanced lung disease of non-malignant etiology. The indications for lung transplant have broadened over the years, and selection criteria have also become less restrictive, and we're going to talk about that over the next few slides. The recipients that receive these transplants face many challenges. These are posed by surgical procedure itself, immunosuppression, drug toxicities, as well as rejection. For successful outcomes, candidates undergo rigorous testing and should be free of significant medical comorbidities and be healthy enough to have a successful outcome. There are inherent risks that are present with transplantation, including limited survival. So timing and listing of transplant is absolutely essential. That means you need to avoid premature listing. You don't want a patient listed too early. You don't want to list a patient when death is imminent. And it's very important as a referring physician to know the local practices at your transplant center, what that center's expertise is, and what their listing policies are, since timing of referral and listing is very much dependent on the philosophy of that transplant center. Centers across the country are going to differ in terms of their listing philosophies and policies. And again, it's important to know what aggressive centers are close to you and what your closest center's expertise is. Your patient, again, arrives for his transplant evaluation, and he asks a simple question: what type of transplant will I receive? You answer A, single lung transplant; B, a double lung transplant; C, a heart lung transplant; D, living lobar transplant? The answer to this question is B, a double lung transplant, and can also be A, single lung transplant. At the time of a patient is placed on the active waiting list, the transplant team also has to identify which specific procedure for which the patient will be listed. For most candidates, the choice is between a single lung or a double lung transplant. The decision is dictated chiefly by the underlying disease, but in cases in which both procedures are acceptable, additional factors such as the patient's age and functional status, as well as that particular center's specific preferences, do come into play. For any patient that has a suppurative form of lung disease, meaning a septic form of lung disease like cystic fibrosis or bronchiectasis, bilateral lung transplant is the procedure of choice. You cannot leave behind a chronically infective native lung because that increases the risk of infecting the newly transplanted lung or allograft. Bilateral lung transplant is also the procedure of choice for idiopathic pulmonary hypertension and for patients with severe secondary pulmonary hypertension. This approach ensues that the cardiac output is evenly distributed between the two lung organs, as opposed to a single lung transplant in which the one transplanted lung must end up bearing the burden of nearly the entire cardiac input, and therefore you could have a risk of attenuated or exaggerated pulmonary edema because of the exceedingly high vascular resistance in the native lung. Now, the two leading indications as shown in this slide for transplantation worldwide are COPD, followed by IPF. COPD in this pie chart is 44% of all single lung transplants, followed by IPF, which is counts for about 34% of all single lung transplants. The number of transplants for IPF, like in our patient that was presented, has been steadily increasing. And in fact, IPF is the leading indication for lung transplantation in the United States. Single lung transplant in patients with IPF without pulmonary hypertension is generally preferred over a double lung transplant. Since recent studies, both from Nathan's group in Fairfax, ANOVA, as well as a recent British study, have shown that IPF patients listed for transplantation for a double lung transplant had an associated risk of a longer waiting time and an increased risk of dying on the waiting list compared to patients who were actually listed for a single lung transplant. So it's more important to remember in IPF, if the patient does not have secondary pulmonary hypertension, the preferred choice would be a single lung transplant. So in this case, our index case, the patient did not have pulmonary hypertension and would likely receive a single lung, but because of his age and the practices at our institution, the possibility for a double lung is still there. Whether or not a patient gets a right lung or a left lung is dependent on their perfusion scan. That actually dictates which side would be preferred to be transplanted. This next slide is the ISHLT data showing the indications for bilateral double lung transplant. Again, COPD is the leading indication for a double lung transplant worldwide, followed closely by cystic fibrosis. Again, cystic fibrosis necessitates the need for a double lung transplant because it is a suppurative lung disease. The indication of a single lung transplant versus a double lung transplant, again, is based on several factors. But as you can see, double lung transplants are starting to make up more and more of the transplants that we are doing worldwide, especially also in the United States. This is not due to more available organs. It is likely inherently due to the fact that the lung allocation system, or how organs are distributed, have allocated more severely ill patients who have the need for a double lung transplant over a single lung transplant. Candidate selection is one that's guided by guidelines that go all the way back to 1996 and then were later revised in 2006. The aim of these guidelines is to assist physicians in referring potential candidates. These guidelines are not based on randomized controlled trials. They're actually based on a consensus of expert opinion and also single and multi-center experience as well as multinational transplant registries. They contain basically general disease-specific information for referral and relative contraindications and absolute contraindications for transplants. These guidelines remain a general statement of suitability, and some of these guidelines and contraindications are being challenged currently, and more evidence is emerging. But the final recipient selection is really dependent on the individual transplant center's practices and expertise. And as I mentioned earlier, these guidelines are undergoing revision, and there is discussion as we have gained and had advances in knowledge of transplant outcomes. The next question is, your patient is undergoing his transplant evaluation. He admitted that he was smoking cigarettes until about 8 months ago, but hasn't touched one since. Is this a contraindication to transplant? A, yes. B, no. The answer to this is no. Your patient quit smoking 8 months ago. Patients must be free of substance addiction, and that cannot be active substance addiction, whether it's tobacco, narcotics, or alcohol, within the last 6 months. So if they are tobacco-free, that includes using, or nicotine-free, that includes using nicotine gum, patches, or actually smoking cigarettes. These patients must not have used any of these substances in the last 6 months in abusive manner. Other general contraindications to lung transplantation include malignancy in the last 2 years. The exception to this is cutaneous squamous and basal cell tumors. There needs to be a 5-year disease-free survival before patients present with other malignancies such as breast cancer and other malignancies. There is a lot of controversy surrounding transplantation for a specific type of lung cancer, bronchoalveolar cell cancer. This is controversial for many reasons, but one of the reasons is the relative reoccurrence of disease early after transplantation on immunosuppression. And this practice to transplant patients for bronchoalveolar cell CA of the lung is not routinely accepted across the country or worldwide. Only certain centers are still transplanting these patients, and there does not definitively exist a consensus on whether or not these patients should be transplanted. If patients have an advanced untreatable dysfunction of another major organ system, such as untreatable coronary disease that cannot be bypassed or stented, they would not be a candidate for transplant. Severe congestive heart failure with an EF less than 30% is a contraindication as well, unless heart-lung transplant is being considered. Non-curable chronic extrapulmonary infections such as HIV, hepatitis B, and hepatitis C have been cited in the 1998 consensus guidelines as well as the 2006 guidelines, but this is being challenged. There are at least 2 cases of patients that are HIV positive that have undergone lung transplantation with reasonable short-term outcomes. We at the Cleveland Clinic have already published our data on patients with chronic hepatitis C that have been transplanted with high viral loads and some treatment prior to transplantation of their viral load and no treatment of their viral load prior to transplant, and have shown both short-term and long-term survival outcomes are equal to those of patients that do not have chronic hepatitis C. So this has been refuted and may be taken into consideration in the next set of guidelines. Yet most transplant centers across the country, although in a survey that was issued a few years ago said that they would transplant these patients, very few centers are actually accepting patients that have chronic hepatitis C and transplanting them due to the questionable risk of fulminant liver failure. In the Cleveland Clinic series by Dr. Garcha and the team, there was no noted fulminant liver failure in any patients that had chronic hepatitis C that underwent transplantation. If a patient has untreatable psychiatric disease that can contribute to noncompliance, that is a contraindication to lung transplantation. That is absolute. The absence of a consistent or reliable social support system is extremely detrimental to a post-transplant course and is considered a contraindication to transplant. Now, your patient gets listed for a single lung transplant for IPF. Congratulations. A few weeks later, he declines and he's placed on mechanical ventilation and might need extracorporeal membrane support, or what we call ECMO support. Is your patient still able to undergo or be considered for transplant? A, no. B, yes. C, maybe. I think the right answer in this situation would be C, because practices from transplant center to transplant center do differ, and many transplant centers there is an evolving area of controversy at many centers on the eligibility of ventilator-dependent patients in the intensive care unit. Ventilator dependence before transplant has been recognized as a risk factor for increased short-term post-transplant mortality, although it does not appear to adversely impact outcomes beyond the first year. Although transplantation of these patients was previously diagnosed, with the lung allocation score changing 7 years ago in the United States, this has actually forced transplant centers to reconsider this philosophy, and now these patients that are on mechanical ventilation have a high allocation score because they are ventilator dependent. And many programs are now willing to maintain and select ventilator dependent patients on their active waiting list, but there is a stipulation usually when you list these patients that you reserve the option to delist them if there are complications or progressive disability or debility overall that may occur. Now, you do anticipate that these patients will get transplanted quickly since they will have a very high allocation in the system. But if they're not, transplant centers that do consider these patients have to be extremely vigilant for any other organ failure or the risk of infection that would lead to a poor early transplant outcome. A few words about these relative contraindications that do exist. Mechanical ventilation is considered one of the relative contraindications because of the post-transplant outcomes. But we do prefer that these patients are New York Heart Class 3 or 4 and ambulatory because we know, again, debilitation can lead to poor outcomes. And as I mentioned, the allocation system has kind of changed our view on ambulation and if these patients should be considered if they do go on mechanical ventilation or subsequently go on ECMO. ECMO has become more and more common, although not all transplant centers are bridging patients from respiratory failure to transplantation on ECMO. This slide actually just illustrates the increase in ECMO cases from 2007 up to 2010 as reported to the International Society of Heart-Lung Registry. And the number of ECMO cases are still not a large part of what we do in transplantation, but there are a substantial number of ECMOs that have been bridged to transplant and are increasing every year. In 2007, 11 patients were bridged to transplant on ECMO, 24 in the year after in 2008, and then 27 in 2009, and in 2010, 38 patients were bridged to transplant on ECMO. There is data from the Cleveland Clinic from David Mason and his group that looked at survival outcomes in bridging patients to transplantation with ECMO versus patients that were on mechanical ventilation, as you can see in the slide here. Patients in this graph, patients who are unsupported and went into transplantation without mechanical ventilation or ECMO is depicted by the blue line and has the best survival. Following behind that blue line is a green line that represents patients that were on mechanical ventilation that were transplanted and their survival. And the red line subsequently is patients that were on ECMO support and subsequently went to transplant and their survival. And this study looked at the UNOS database from 1987 to 2008 and identified 51 patients total that were bridged to transplant on ECMO. The study found the ECMO-bridged patients had the worst survival, even lower than that of those patients that were on mechanical ventilation, and you can compare the green line and the red line. There was an increase in mortality that was only evident, though, the first 6 months after transplant. After that time period, these patients that were on ECMO or mechanical ventilation, all of these lines, actually, if you extend this out, end up merging with those patients that came into transplant unsupported. So if you can get them out the first 6 months after the first 6 months, these patients can do relatively well and can have a good early survival after 6 months, similar to those patients that are unsupported. And it's important to keep this in mind. Now, the interesting thing about this study is that we really don't know what type of ECMO was used to support these patients. Was it venous-venous ECMO or was it veno-arterial ECMO? We don't know if these patients were ambulatory on ECMO. All we know is that they were bridged to transplant on ECMO. Now, should we totally skip intubation as a bridge to transplant? Is it possible to totally not think about putting these patients on mechanical ventilation and putting them on ECMO to help them with their respiratory failure and their oxygen needs or hypercapnia? And this is a picture depicting that this is possible. This was a patient at the Cleveland Clinic who was our first what we call ambulatory ECMO. A cannulation was placed by axillary approach. You can see in the picture to the left where he's sitting in the chair watching TV that there's a large bump over his left shoulder, and that's where the cannulation was padded. And this patient was able to get up out of bed on BiPAP therapy, walking in the hallways with the team supporting his ECMO cannulas, which you can't see well in the picture to the right, but you can see him walking with the team. This approach, allowing patients not to be intubated, not to be sedated, allows them to be conditioned and rehabilitate and hopefully improve outcomes in this group that is bridged to transplant with ECMO. By doing this, you would hope to improve outcomes. And multiple centers in both the United States and Europe have actually demonstrated excellent outcomes with ambulatory ECMO, or what we call AECMO. Contemporary ECMO technology and management protocols have really opened the door for patients to be listed for lung transplantation who have an acute exacerbation and need to be bridged without the use of mechanical ventilation, and again, allowing them to be ambulatory. And it frees them from heavy sedation and ameliorates the risk of deconditioning and ventilator-acquired pneumonias. Again, multiple centers have now reported good outcomes with removing patients that do get on a mechanical ventilator while they await transplant, and they get transitioned to ECMO. While they're on ambulatory ECMO, they're actually able to eat, participate in their own care, work out more extensively with physical therapy. Besides just ambulating, they can work out on a bike. They can also work out on a treadmill. Sometimes this form of ambulatory ECMO can be difficult, and these patients will end up having more shortness of breath, although their saturations may be maintained because of ECMO. And these patients may be limited by the work of breathing, and they are just awake. They may not be ambulating as much as we hope, and we call this now awake ECMO. Ambulatory ECMO is now being actually addressed as awake ECMO. One of the other controversies that exists out there, and a relative contraindication to transplant, is age. Many transplant centers still define an age cutoff for transplant eligibility, and usually that's 65 years old. It's kind of been arbitrarily assigned. Supporting this policy, advanced age has been consistently identified as a risk factor for increased post-transplant mortality. Nevertheless, there is a growing trend, as this slide shows you from the International Society of Heart-Lung Transplant Registry. If you look at the last two blocks of columns, ages over 60 have increased in the past few decades of transplant. The orange bars are the most recent era of transplant from 2006 to 2012. And steadily, that orange bar has increased when you're looking at older ages or more advanced ages from 60 and above and greater than 65. This has actually increased more than in any other era of lung transplantation. And again, this trend has been probably most pronounced in the United States, where in 2008, in fact, 19% of the patients were over 65 years old. And this is now a new philosophy. Transplant centers are looking more at functional status and functional age or physiological age rather than chronological age. But this is still quite controversial because some of the long-term outcomes with advanced age is questionable depending, and there's some of the research that has come out from single centers has indicated that the upper age transplants may have more issues with 3-year survival and a decreased 3-year survival. So again, there's really no consensus, but the general acceptance is greater than 65 is considered a higher risk transplant. Only specific transplant centers will consider patients over this age. This graph from, again, the International Society of Heart-Lung Registry looks at the two most common disease states for transplantation in the older individual. And those disease states are COPD and IPF. And COPD is represented by the bright yellow line. And these are COPD patients over the age of 65. And the bright pink line represents IPF patients over the age of 65. And it compares these two groups to other patients that are younger than 65 with COPD and younger patients with IPF, again, younger than 65 years old. And you can see the overall survival is decreased in those patients that have COPD or IPF that are over the age of 65. And if you don't look at it even by specific diagnosis, older patients in the ISHLT registry have shown a decreased survival compared to all other ages of patients, but both in mid and long-term survival. Some of the other specific relative contraindications that need to be mentioned here are weight. There is a BMI cutoff for transplantation, with 30 being the upper limit for weight. And the reason why this exists is due to supporting and mounting evidence that obesity is an inflammatory state, and the risk of primary graft dysfunction does increase in a patient that is over a BMI of 30. So very important to remember in consideration for referral, where is your patient's BMI? In addition, the lower BMIs, less than 18, do have an impact on survival and in terms of also healing. And this usually applies to groups such as the cystic fibrosis patients and some of the COPD patients. And every attempt should be made to try to increase their BMI with muscle mass. And this can be challenging because many times in effort to gain weight, these patients will gain more fat and less muscle, and will actually lead to some difficulty with their respiratory status with their current disease state. One of the aims of the guidelines is disease-specific considerations, and the familiarity with a natural history of underlying disease and the prognostic factors are essential in the timing for referral and listing. There are prognostic indices that do exist, but these can be imprecise, and the patient's individual trajectory is very important to keep in mind. Also, as a referring provider, look at their functional status, their quality of life, and what's the willingness of this patient to accept the risks and uncertainties that go along with lung transplantation. The first disease state that we'll talk about is COPD. The variable natural history of COPD can be quite protracted. Long-term survival with COPD without a transplant can happen. It makes it difficult to determine the exact time point to actually consider transplant. Many of these patients can go on for very many years without a drop in their FEV1. Listed here are some of the specific guidelines and physiological parameters that should be considered when you are looking at a COPD patient for transplantation. The Bode index of 7 to 10, or at least one of the following, should be looked at: a history of hospitalization for exacerbations associated with acute hypercapnia, whether or not these patients have pulmonary hypertension, or cor pulmonale with O2 therapy or without, an FEV1 less than 20%, or a DLCO less than 20%, or homogeneous distribution of emphysema. These patients should have exhausted all medical and surgical options, including the option of lung volume reduction surgery or endobronchial valve placement. IPF guidelines are really important to follow closely because there are no proven therapies for this disease, and there is a limited median survival from the time of diagnosis. Referral is really recommended at the time of diagnosis. If the patient has histological or radiographic evidence of UIP, and any of the following, this patient should be referred and followed closely. The DLCO less than 39% or a 10% decrease in the FBC during the 6 months of follow-up, a decrease in their pulse oximetry less than 88% on 6-minute walk, or honeycombing on the high-resolution CT with a fibrosis score less than or greater than 2 is very important to keep in mind in referring these patients. Early referral is what I stress in these patients. We see too many of these patients too late and too sick. For IPF in combination with COPD, there are no specific guidelines except for this is a unique subgroup of patients with IPF and concomitant COPD. Lung volumes and many times the spirometric parameters are typically well preserved and could be actually misleading. They have a higher risk of developing pulmonary hypertension than with patients with IPF alone. And therefore, if these patients do have PH, this portends with a poor prognosis, and early referral is the key in these patients. Cystic fibrosis has models that are present for death, and they do exist. But generally, cystic fibrosis doctors follow the guidelines of an FEV1 less than 30% or rapidly declining lung function. If the patient is a female or has diabetes, or they're increasing their oxygen requirement, now hypercapnic or having pulmonary hypertension or having hemoptysis or evolving organisms and needing more, having evolving resistance patterns to particular organisms or being admitted frequently, these patients should be considered for transplantation. For pulmonary hypertension, these patients should be on maximal medical therapy, have a low walk distance, failing IV epoprostenol or its equivalent, or having a cardiac index less than 2 or right atrial pressure greater than 15. These patients absolutely should be considered for transplant. Now, a few words about the IPF patients. They do receive a lower priority on the new allocation system, but an exception score can be obtained from the UNOS board that would place these patients in the top 10% of all scores nationally if certain criteria are met. Sarcoid also has a variable natural history, but it's favorable in general. But if these patients do get pulmonary hypertension or are hypoxic at rest or now have a right atrial pressure greater than 15, they should be referred for transplant. Prior to being listed, your case patient asked, what's the survival for lung transplant with patients with IPF compared to all lung transplants with other diseases? Well, what your patient is asking are, number one, what's the outcomes from transplant, and what's the specific outcome for his disease? And the options are A, much better with other diseases, B, worse than other diseases, C, the same as other diseases, D, no data is available on this. Well, all transplant patients are followed very closely in an international registry and a national registry, and this is data again from the International Society for Heart-Lung Transplant from 2013, which shows survival by diagnosis. And the bright blue line that is at the bottom is IPF survival, and you can see survival from IPF starts to break off relatively quickly from other diagnoses, including pulmonary hypertension. Relatively quickly after the first year, and there is a change, or actually between the second and the third year, and there is a relative change in survival with a decreased survival compared to all other disease states. And this is important to know. Interestingly enough, with pulmonary hypertension, early survival can be poor, as you can see with the yellow line, but quickly these patients, as their hemodynamics change, their right ventricular function improves, and other immediate postoperative complications resolve, these patients do very well and enjoy a very good survival. As you can imagine, cystic fibrosis, especially since this is a cohort of patients made up of much younger patients, do extremely well after transplant with a very good survival, so as depicted by the bright green line on this graph. Transplantation is hitting its 50th year and its 50th anniversary, and if you look at the data by era in terms of survival, the slope of the curve has not changed significantly, but there have been improvements that have been made in the median survival that are listed in the right upper corner in the box that illustrates each different era and the median survival in terms of years. And from 2004 to 2006 to 2011, the median survival is considered around 6.1 years for all comers. What do these patients die from? The number one reason or cause of death in lung transplant recipients after the first year is bronchiolitis obliterans syndrome, or what is equivalent to what the layman would say is chronic rejection. It's now being retermed as chronic lung allograft dysfunction, but this is still undergoing a revision in terms of the definition. But as you can see from the data from the ISHLT registry that's shown in this slide, the red line depicts bronchiolitis obliterans syndrome, and it increases at a rate after 1 year and goes up and continues to occur at approximately 10% each year, and is the number one reason for death in these patients. Patients die also of complications of bronchiolitis obliterans, and then usually that's infection. If you look at the green line on this chart, you can see infection peaks from 31 days to 1 year. And the reason for this is in the first year, immunosuppression is extremely high and kept at high levels as the lung starts to accommodate itself in its new environment. And this risk of infection decreases as immunosuppression is actually lowered, but continues to be a problem throughout transplant for all of these recipients. Malignancy, which is represented by the yellow line, continues to increase as the patient lives on. And malignancy, which is non-lymphoma or non-post-transplant lymphoproliferative disease, can be of various types of malignancies: recurrence of breast cancer, colon cancers, severe skin cancers that may occur are extremely common. But this does increase in its incidence, mainly due to the immunosuppression that these patients have been under for many, many years. The cardiovascular deaths are relatively uncommon, and you can look at the blue line that's depicted here. The cardiovascular deaths are, again, rare, mainly because these patients undergo rigorous evaluation for their cardiovascular status prior to transplantation and are monitored very closely. But as we're changing our policies in terms of accepting patients that need coronary artery bypass or a stent prior to listing for a transplant because they have concomitant coronary disease, this may actually change, and risk from cardiovascular death may actually increase. We'll have to see as the years go on, and some of our policies do cause this change in selection of recipients. Let's go back to our case. Our patient returns after a single lung transplant, and he's actually doing extremely well 1 year after his surgery. And he asks you if he can go back to work. As a physician, you reply, A, no, never. You need to stay at home. It's just too risky. B, yes, it's okay. C, only part-time since you're still at risk for infections. D, none of the above. Well, this is a tough question, but the answer to this is B, yes, it's okay. Obviously, if this patient and his occupation as a physician, it puts him at higher risk for being exposed to patients that are infected and is in a high-risk subspecialty, there may be caveats to this answer. But in general, most of these patients would like to go to work or return to work in some capacity. This is data, again, from the International Society of Heart-Lung Transplant Registry, and there's quite a reasonable number of patients that are working part-time as depicted by the pink or magenta bars that are noticed at the top, both at 1 year, 3 years, and 5 years. There are patients that are working at least full-time, and this increases as patients get out from their first year, mainly because that first year they use to get used to the medications. Doctor's visits are more common to occur more frequently, and as they get out from transplant and are in a routine of taking their medications and have adjusted to the side effects, these patients are able to return to work. There is still a large group of patients that are not working, and some of this representation may be by the fact that if you're looking at patients that are older than 65 who are getting transplanted or older than 60 who have IPF or COPD, they may be better off going on disability or actually retiring from work than returning to work. And that might reflect that change in practice of ages and diagnoses that we're transplanting for. And this question is actually based on a physician. This is Dr. Timothy Francisco, who has allowed me to share his story with you as well as these pictures. Dr. Francisco, he was not a transplant patient in this photograph, but he actually was in medical school, and he subsequently used to for extra money work at SeaWorld and was an elite athlete, as you can tell. He was diagnosed with a rare disease called Castleman's disease and suffered from obliterative bronchiolitis, and this is a picture of him with oxygen on. There's a tremendous amount of muscle loss that you see here. He underwent a double lung transplant, and I'm so happy to report this is his 10th year from transplantation. Dr. Francisco is to your far left with the surfboard underneath his arm, and he is doing extremely well, enjoying his life. He has returned back based on our advice in his last question. He is working and has returned to work. But all of these things have been made possible because of his transplantation. And the indications, the outcomes are constantly evolving and changing. And it's important for you to know who your referring center is and what their practices are and their expertise. I'll stop here, and I'd like to thank you for your time.
Thank you, Marie. In this case-based presentation, Dr. Budev provided an introduction of lung transplantation and discussed its general indications and contraindications. She presented the concept of the transplant window and the optimal timing of transplant referral for patients with various end-stage lung diseases, including idiopathic pulmonary fibrosis, chronic obstructive pulmonary disease, cystic fibrosis, pulmonary hypertension, and sarcoidosis. Dr. Budev discussed the indications for single and double lung transplantation. She reviewed overall survival as well as disease-specific survival based on information from the International Society of Heart and Lung Transplantation. She briefly mentioned some of the current controversies in the lung transplantation field, including the use of chronological versus physiological age to determine eligibility for transplant. I hope that you found Dr. Budev's presentation on lung transplantation to be a useful update on this topic and that it will help you in your discussions with your patients and in making decisions regarding when to refer your patients with end-stage lung disease for a transplant evaluation. Finally, on behalf of myself, Dr. Budev, the Respiratory Institute, and the Cleveland Clinic, I would like to thank you for listening to this Respiratory Virtual Grand Rounds presentation.